Cervical cancer is the second most common gynecological cancer. It is primarily caused by a viral infection, the human papillomavirus (HPV), which represents the main risk factor for the development of this type of cancer. The diagnosis of this cancer is based on a clinical, endoscopic, and histological approach. Early diagnosis allows for more effective treatments and significantly improves the chances of cure. The clinical classification of cervical cancer, established by FIGO, International Federation of Gynecology and Obstetrics, is used to assess the extent of the disease. This classification divides the disease into different stages according to the tumor's extent and its invasion into surrounding tissues. Stage 1. Cancer is limited to the cervix with no spread to other areas. Stage 2. Cancer has spread beyond the cervix but does not yet involve the pelvic walls or the lower part of the vagina. Stage 3. Cancer has invaded the pelvic wall or the lower part of the vagina. Stage 4. Cancer has spread to other organs such as the bladder, rectum, or other parts of the body. The main objectives of the treatment are to eradicate the tumor, improve patient survival, prevent any recurrence, and address the patient's psychological well-being. Surgery can involve conization, which removes the part of the cervix affected by the tumor. In more advanced cases, a total hysterectomy, complete removal of the uterus, may be performed. A more radical procedure is the extended colpo-hysterectomy, which also includes lymph node removal. For locally advanced tumors, a pelvectomy, anterior, posterior, or total, may be performed to remove affected tissues and organs in the pelvic region. Radiotherapy, used to destroy cancer cells, can be administered as uterovaginal brachytherapy, placing radioactive sources directly in or near the tumor, or as external beam radiotherapy, directing rays toward the affected area. Chemotherapy, depending on the type and stage of the cancer, it may be used alone or in combination with surgery and/or radiotherapy. Cervical cancer screening is primarily based on the pap smear. It is recommended for women aged 25 to 65 years. After 2 negative pap smears spaced 1 year apart, screening can be performed every 3 years. In the case of an abnormal pap smear, diagnostic investigations must be conducted based on cytology results to evaluate the presence of precancerous lesions or HPV infection. HPV vaccination is based on 2 main types of vaccines. Bivalent vaccine protects against HPV type 16 and 18, responsible for the majority of cervical cancers. Quadrivalent vaccine also protects against HPV types 6 and 11, which often cause genital warts. Vaccination is strongly recommended for girls aged 14 to 15 years, before the onset of sexual activity. It can be administered up to 23 years, provided the individual has not yet had sexual intercourse or at the latest 1 year after sexual debut.